Thank you so much for being here, really, to the nomination committee and to my mentors who put my name up for this. I'm incredibly honored. I have no disclosures. While preparing for this, I was reading some of Dr. Feigenbaum's early work, and I was just incredibly astounded at the impact he has had. I found this journal article. This is one of his very first journal articles from 1967. And incredibly, this was a quote at the beginning of the article. For nearly 4 years, we've been working, 4 years, with ultrasound in an attempt to utilize this form of physical energy for diagnostic purposes in cardiology. We're 4 years into ECHO. This is 1967. And in this paper, he's describing quantification of volumes and function in the ventricle, which is incredible. And 57 years later, he's senior author on this paper, obviously looking in a much more sophisticated way at ventricular function. And just, I'm just completely honored and would hope to have just a fraction of this legacy and what he's created here with ACE. To change topics a little bit, so my career has been focused on combining disciplines. So I have really strong interest in sort of three main areas. This is genetics, clinical outcomes research, and cardiovascular imaging. And I kind of want to talk about the intersection and interplay of these. And I wanted to make a graphic, obviously this one's very ugly, of how these intersected together. And I said, well, I'll use AI. I use AI on a lot of my work. And so I went to OpenArt AI and I said, can you make me some word art of these three things to make it a little prettier for my presentation? And it made this, which, at first it looks kind of pretty. And then you look at it, I'm not really sure what's going on. I think that's a spine in the middle. There's like some lungs, a kidney, 5, 6, 7, 8 hearts. I'm not sure. I don't think there's any words in English. So, it just tells us a little bit. And I said, okay, well, it's AI. I know I have to train it a little better. I have to get a little more guidance. And I gave it a little more guidance, and I got this, which pretty at first look. There's something that looks like a heart, but really there's 2 hearts. One's short, one's long. There's one word in English. I see clinical. There is a double-strand DNA, I think. So, I think this is just a great lesson that while AI has lots of promise, I use it a lot, we still need to give a lot of guidance and use our clinical opinion and insights to inform when we're training these models. So, what I'm really going to focus on is connecting detailed imaging. Like all of our jobs here, we're imagers. We focus on observation, pattern recognition, accurate quantification, high rigor, combining this with cardiovascular genetics and rigorous clinical outcomes research. And we saw some great examples of using imaging and outcomes research right before this with our abstract presenters. But I think we haven't crossed over in the field of genetics as much and rare disease. It is very tempting to take these really large data sets and really common problems and employ our tools in those, but I think we also need to apply it to rare disease. I think we can definitely improve accuracy of genetic diagnosis, guide prognosis, and guide treatment. So getting to phenotype and genotype, a lot of genetic work looks at correlating these. How does phenotype predict genotype? How does genotype predict phenotype? And just to remind people, I know most people know this, but phenotype is what we observe. What is there on our physical exam, our clinical findings by imaging. Some examples, pectus carinatum is a phenotype, congenital diaphragmatic hernia. Genotype is the actual DNA findings, right? For example, 22q11.2 deletion syndrome, previously called DeGeorge, or a Notch1 variant, which causes non-syndromic bicuspid aortic valve. So traditional phenotyping is, what we learned, what we've all been tested on. Let's look at the patient, let's find some features. This is a patient with Down syndrome. Or maybe even a little trickier, more subtle things. This is a patient with Noonan syndrome. And we say, here's the phenotypes. If we say, what's a phenotype? This is what we do. But to be honest, cardiology teams are not awesome at that. We're really at looking at a patient and finding all the things. We're not doing always a complete exam head to toe looking for genetic changes. What we are really good at is cardiac phenotyping. For example, everybody in this room can look at this echo, right? You see that there's aortic root dilation, you see mitral valve prolapse, you see mitral annular disjunction, and you say, this patient probably has Marfan syndrome or something related. I don't even need to see the patient. Again, you look at this patient, right? You see asymmetric septal hypertrophy. This is hypertrophic cardiomyopathy. And when I tell you this patient is under 1 year of age, you say, well, it's probably not sarcomeric. It's probably not traditional hypertrophic cardiomyopathy. It's probably a phenocopy or something that looks like that. And this is Pompe syndrome. You look at this patient, it's the parasternal long axis. You see this small sinotubular junction. Immediately when we see this, we know this is probably Williams syndrome or something related to elastin without examining the patient. And sometimes the patient has very subtle features, but you, as the imager, can inform the genetic diagnosis and tell them what to do based on a simple parasternal long axis. And another example, this is a patient a little more complicated, but who has a ventricular septal defect, posterior malalignment of the ventricular septum. You can see that the LVOT is narrowed, there's an interrupted arch, and the chance of this patient having 22q11 deletion syndrome is really high. You don't need to look at the patient. You don't need to see if they have a broad-based nasal bridge. This patient probably has 22q based on simply an echo. And I will say, when people are looking now, genetic studies are becoming very large and big databases. We have the UK Biobank, we have all these large databases, and the typical phenotyping, especially for cardiac, is like LVH, tetralogy of Fallot. And I would argue we need to fight to have deep phenotyping, which is if you change LVH to LVH with asymmetric septal hypertrophy presenting less than 1 year of age, we're going to have a lot more accuracy for diagnosis and to build these better models. Instead of saying tetralogy of Fallot, if we say tetralogy of Fallot with a right aortic arch and aberrant left subclavian, that actually changes things dramatically. Just for example, this is, everyone here knows that in tetralogy of Fallot, you have a chance of 22q11.2 deletion syndrome. But if it's tetralogy of Fallot with a left arch, normal branching, the chance of having a 22q deletion syndrome is only 6 to 11%. But if you add that there's a right arch and mirror image branching, which you may not always look at, the risk is doubled. And if in fact the pulmonary valve was not stenotic but atretic, and there's multiple aortopulmonary collaterals, the chance is multiple fold that. And so this is, again, just based on the imaging phenotyping where we can inform. And as we're building these bigger models, if we can fight to have more rigorous phenotypic data, they're going to be a lot more accurate. I'm going to go through an example in a couple of projects looking at deep phenotyping and aortopathy, which I'll refer to as hereditary thoracic aortic disease, or HTAD, and that talks about how deep phenotyping can affect outcomes, and deep phenotyping and laterality congenital heart disease, more in helping with diagnosis. So first, these are just some of my incredible patients. I run a very busy clinic in HTAD, and our whole goal is to try to have these patients live longer, healthier, less medicalized lives. And so the question is, are there imaging phenotypic characteristics, which have also been called imaging biomarkers, or now we're calling it radiomics, that can allow us to risk stratify and personalize therapy to decrease morbidity and mortality? This is on an individual basis. And just to throw it in there, this is not a fetal talk. Fetal's my other love. There's a little bit of a misnomer that these, aortopathies kind of come with age. And I will say the skeletal features come with age, but the echo features are there from prenatal life. These are just some examples. Now, the patient on the left, this is a patient with neonatal Marfan syndrome. This is a very severe form of Marfan syndrome, so you do see the typical skeletal features. But the patient on the right has a very mild form of Loeys-Dietz syndrome. This is TGFB2, it's Loeys-Dietz type 4, it's very mild, but in the fetus, at 24 weeks, we can see aortic root dilation. It is there from birth for the vast majority of patients. I've yet to not see it in a fetus we knew was diagnosed, so we just have to look for it. I think more often people here are looking at a patient like this. So a 13-year-old patient comes to cardiology clinic, we're told the aorta is dilated, and here you see a 4.1 centimeter aorta. And what do we do about that? Should we be worried? Do we put them on medicines? Do we refer for surgery? And of course, the first thing we need to find out is the genetics, so a little diversion to genetics. Just as a reminder, we know that the gene affected really affects the outcome. This is risk of dissection or rupture. We know that there are high-risk conditions like vascular ADS, Loeys-Dietz type 1 and 2, ACTA2 disease that have a very high risk, even in young life, of aortic dissection or rupture. Then you have those with certainly high risk, not as high as the others, like Marfan syndrome, Loeys-Dietz type 3 to 5, and FLNA disease. You have those that it's increased in the population, like Turner syndrome and BAV, but it's usually in adulthood, it's mildly increased. And then you have patients that are dilated, but really have virtually no reports of dissection or not above population frequency, where we probably don't need to worry. So of course the genetics is the first thing you want to look at. And just if you guys haven't seen this paper, this is from the Montalcino Consortium, a group that I'm really proud to be a part of. It's a beautiful paper in JACC last year. But this looks at, it has a bunch of different genotypes, but these are 4 different Loeys-Dietz genes showing freedom from first aortic event, that it varies by gene. And for each gene, there's actually variants. So for ACTA2, the variant, the actual single base pair misspelling you have predicts freedom from event. And you can see, like, I follow about 7 kids with this variant, and this is like a super scary variant where almost everyone has had a major event by age 20. So, but then beyond this, once you know the genotype, can we use imaging phenotyping to manage these patients? And absolutely. So we're going to go through some of those features. First, the imaging feature 1 is arterial tortuosity. Now this is common, it's going to be on our boards in Loeys-Dietz syndrome, but it's actually seen in many aortopathies. These are just some examples that kind of run the spectrum. We have Turner syndrome, we have Marfan syndrome, we have arterial tortuosity syndrome. And some work we did a few years ago showed that quantifying this degree of tortuosity, this is using the vertebrals where it manifests the most, it's the easiest to see. It's just the 3D length over the crow's flight length, the percent excess. We call that the vertebral artery tortuosity index. That if you put that in a model, that predicts freedom from type A aortic dissection or death. And in a multivariable model, putting in both the aortic root Z-score and the diagnosis, it is the only thing that retains performance in the model. So it's a very strong predictor of outcome. And even within the same mutation, this is just an example of a family. We have 14 members have Loeys-Dietz type 4. This is TGFB2. 2 people have dissected. The rest are all doing fine. The 2 that dissected had a VTI around 200, and everyone else was lower. So this shows that it's sort of representing the modifications within that person, not just the genotype. Because when we first started publishing this work, they said, well, it's just the genotype. But we all have inherited modifications that make you higher risk or lower risk that we haven't discovered yet. But this seems to be manifesting that and representing it. So it's a great biomarker. Oh, sorry, so these are the low and these are the high. And since we published, so that was quite a few years ago, this has been validated in many studies. And that arterial tortuosity, whether you're looking at the vertebral arteries or the carotids or the aorta. And in fact, this was added to the most recent AHA guidelines last year. This is just a table showing some of the Loeys-Dietz genes that they've added modification of management, personalized management by presence of high-risk features. And one of those high-risk features is marked arterial tortuosity. So we'll look at HTAD feature number 2. This is bicuspid aortic valve and Loeys-Dietz syndrome. So these are 2 graphs. This is age at the bottom. This is root diameter up on the left and Z-score up on the left. Each line is a person. Each color is a different gene of Loeys-Dietz. You can clearly see the red, TGFBR2 are the most severe. But if we add asterisks for BAV, you can see that all the most severe patients have BAV. And this is 10% of the population with Loeys-Dietz. So it's different than saying, oh, well, that's the 1 to 2%. Of course, BAV, you're going to have a more dilated aorta. This is actually something pathogenic going on in these patients. And that lets us know that if you have BAV in the presence of Loeys-Dietz, it's associated with increased accelerated dilation and early need for surgery. They need to be monitored more closely. HTAD feature number 3, ventricular dilation and dysfunction. So this is recently published by my colleague, Dr. Weigand, who's an MRI expert and also echo, and measured volumes, both using MRI and echo, looking at patients with Marfan syndrome and looking also at ejection fraction. And if you look, the one on the far left is with lack of volume loading, with no MR, over half the patients had a dilated left ventricle. And again, looking with lack of volume loading, half the patients had a decreased ejection fraction. Now, these are subtle, but this is children and definitely helps us understand who might be at risk of post-operative cardiomyopathy. And these are patients we need to watch long-term. Another HTAD feature is mitral annular disjunction. This is getting a lot of attention. This is work published by my other colleague, Dr. Doan, who's presented here today. Looking at the prevalence of MAD in children with Marfan syndrome, it's very, very high, over 50%. And this is work that he did with one of our fellows showing that it has a high association with arrhythmias, even in children with Marfan syndrome. So again, all these imaging deep phenotyping factors can help us manage patients individually. These are patients you want to probably get a Holter. We need to understand long-term how frequently that needs to be because it's still pretty uncommon. And the last imaging factor I want to talk about is severe filament A disease. This is just an example of recognizing patterns. So a few years ago, filament A is a smooth muscle protein that causes severe lung disease in children and can cause aortic disease. But I brought several of these patients and realized they all had the exact same combination: pulmonary hypertension, ascending aortic dilation, aortic insufficiency, and hypermobility. That's a weird combination. Like, we've read a lot of echoes. That's a really bizarre combo. And we looked at 6 patients initially that came to us. These are their echoes mixed with CTs and MRIs. And they all had like almost the exact same phenotype when you look at it. And now I've diagnosed probably 4 or 5 more patients just through the echo lab who just show up and you say, oh, PH plus ascending aortic dilation, central AI, we need to do genetic testing. And so finding these is just an example, but finding these, you have the power as an imager to really change the course because they have strong management. They can get transplant for lung disease, they respond to antihypertensive therapy for the aortic dilation, and they certainly have a risk of dissection. So lastly, I wanted to switch topics and talk about congenital heart disease and deep phenotyping. So of course, we all know there's a connection between congenital heart disease as a massive group and genetic conditions. You know, classic ones are the one I keep mentioning, 22q11 deletion syndrome and Turner syndrome. But it gets more complicated than that. So we really, again, should be using deep phenotyping. You might say, well, what genetic conditions are associated with coarctation of the aorta? Well, coarctation with what? So if we say, here's a patient with coarctation of the aorta, BAV, arch hypoplasia, membranous VSD, and posterior malalignment, that is not your typical left-sided lesion. That is going to be a conotruncal defect, and you're probably going to have DeGeorge. If you say, well, it's coarctation plus BAV plus valvular aortic stenosis, and that's it, genetically, that is going to be a left-sided lesion probably. Your highest risk is for something like Turner syndrome or other left-sided lesions, not one. But if you say, oh, I have coarctation of the aorta, but I have an AV septal defect, I have double outlet right ventricle, I have TPVR, bilateral superior vena cava, this goes in the laterality. That is a totally different group of genes, right? And so if we're filling out forms for phenotyping and say they had coarctation, if it's not informed by all these other things, they're going to be looking in the wrong genetic pathways, and there's going to be a lot of noise. And lastly, if you say coarctation of the aorta, but they also have supravalvular aortic stenosis, bilateral branch pulmonary stenosis, that is going to be an elastin-mediated phenomenon, totally separate than these other three. And again, we're looking at a different genetic pathway. So it's really important, and I'd say that imagers are the ones that can point these things out. So this is like our current composition of emerging genetic-based classifications with the phenotypes in the middle. These are the kind of congenital classifications, and the pathways that are affected genetically outside. And these are, you know, the current 8 slices of pie. What I think is fascinating is Epstein anomaly really is like probably a cardiomyopathy, not really a true congenital heart disease genetically. And just an example of a paper. So this is a paper we just published a few months ago looking at nodal variants and that they're associated with a continuum of laterality defects from TGA all the way to heterotaxy. So for those of you who don't know, nodal is kind of like a directional protein. It tells you what way the heart should loop as you're looping in development. It says go this way, go this way, go this way. And if it's not functioning, the cells just have to guess. Your heart might loop the right way, but it might not. And we collected patients from our population at our hospital and through publicly available data sets and realized that almost everyone with a nodal variant had one of 6 phenotypes. This is a normal phenotype, but had TGA, double outlet right ventricle with malposed great arteries, tricuspid atresia with D malposed great arteries, or these two are L-looped, leftward looping, either CCTGA or double outlet left ventricle, or right atrial isomerism subtype of heterotaxy. Nobody had left atrial isomerism. And what this realizes is that historically we were taught that TGA is a conotruncal disease. It's like tetralogy, it's like truncus, because it's the outflow tracts. But it's not, it's a laterality defect. And these specific ones were always caused by nodal, which I think is fascinating. We also employed something called the HPO terms, human phenotype ontology. So this is a really neat thing. We're using a standardized vocabulary of phenotypic abnormalities for the international genetic community. So you basically code, they have all these different congenital heart terms, and you code it 01, 01, 01. So this is an example. You know, there's about 50 congenital heart terms. But you code it, and then you can employ it in these big AI algorithms to help predict. And the more accurate, the more ones you code, the better. So this was an example. We looked at a clustering analysis of all our nodal variants and found that there were kind of 5 main clusters, and they clustered both phenotypically and genetically, and it helps us understand those genetic pathways. So basically, in summary, imagers have some of the greatest insights into deep cardiac phenotyping, and harnessing and employing these deep phenotyping tools and collaborations, I think, can really push scientific advancements and help understand these other advanced tools, help push these advanced tools we have. Also, deep cardiac phenotyping and HTAD can help modify prognosis and management on an individual basis. And some examples of this includes arterial tortuosity, BAV, evidence of cardiomyopathy, and MAD. And systematic standardized phenotyping language, for example, HPO terms, can accelerate research efforts, for example, in both rare disease cohorts and large cohorts to inform ML and AI models specifically. So I just wanted to thank there's many people, but mentors, collaborators, and of course our funders, and some fun pictures from our Echo Lab and our genetics team. So thank you guys.
Thank you so much, Dr. Morris. Phenomenal. It's so good, actually. It's so rewarding. Shaine and I worked together some years ago on the GenTech project, but you taking us through this journey of recent history and future of aortic diseases in children is just phenomenal. Thank you so much. I want to give you a plaque in recognition for this presentation. Thank you.